Good evening, everyone. On behalf of TaskMed, I would like to welcome you all to Medcast Insights into Healthcare, a learning initiative by TaskMed. Today, it's a great pleasure to have with us Dr. Rajesh Jain, who is a consultant endocrinologist at Specialist Clinic, Jalandhar. We welcome you, sir. Sir, we look forward to hear from you on today's topic of discussion, insights into diabetic dermopathy. Over to you, Dr. Jain.
Thank you, TaskMed team, for choosing a wonderful topic, dermatological manifestations in diabetes. Now, when we talk about diabetes, we are constrained with the treatment of hyperglycemia. We are all obsessed with management of hyperglycemia, managing the glycemic status. When we go sometimes beyond glycemic status, we go towards control of blood pressure, control of dyslipidemia, control of NASH, control of retinopathy, control of retinopathy, control of neuropathy. But since we all know diabetic affects all the organs of the body, and skin is an important one. But dermatological manifestations are one of the least bothered and least discussed manifestation or complications of diabetes. So I really appreciate their concern for choosing such a nice topic, dermatological manifestations in diabetes. And when we go through these slides, I hope we all get a bit more intelligent about dermatological manifestations in diabetes, how to go about it, how to diagnose, and some principles of management. We will not be discussing mainly about the products or anything, just what outline of how to go about. So dermatological manifestations in diabetes, and diabetes affects around 37 to 70% of our diabetic population. They will have some or the other dermatological manifestation. And most important is that dermatological manifestations may precede development of clinical diabetes, because many patients they present to the dermatologist with a dermatological complaint, and when they are evaluated, they are known to have diabetes. That may be subclinical, hidden, or many patients may be pre-known diabetic also. Many persons, they have a misconception that dermatological manifestations are more in type 1 diabetic patients. However, the prevalence is similar in both type 1 and type 2 diabetic patients. Cutaneous manifestations or infections are more common in type 2, whereas autoimmune related lesions are more in type 1. And good metabolic control, that is good glycemic control, may prevent and help some and cure some of the dermatological manifestations. So dermatological manifestations are not that uncommon. Incidence is around 30 to 70%. Prevalence is both type 1 and type 2 are similar. Good metabolic control may prevent and also help in the cure. And most important is that dermatological manifestations may precede the development of clinical diabetes. Broad classifications are the dermatological manifestations or skin lesions or whatever they may present with. Skin lesions that are strongly associated with diabetes, skin lesions of infectious etiology whose incidence is increased or more in patients with diabetes, lesions secondary to complications of diabetes, and lesions related to treatment of diabetes. So lesions strongly associated with diabetes, lesions of infectious etiology, lesions secondary to complications of diabetes, and lesions related to treatment of diabetes. Common and rare skin disorders in diabetes. Most common are diabetic dermopathy, necrobiosis lipoidica, diabetic bulle, acanthosis nigricans, scleroderma, vitiligo, disseminated granuloma annulare, pruritus, lichen planus, diabetic thick yellow skin, eruptive xanthomas, diabetic rubeosis. So these are few of the common and skin disorders that are otherwise rare but common in diabetes. These are diabetic dermopathy, necrobiosis lipoidica, diabetic bulle, acanthosis nigricans, scleroderma, vitiligo, disseminated granuloma annulare, pruritus, lichen planus, diabetic thick yellow skin, eruptive xanthomas, and diabetic rubeosis. Diabetic dermopathy. These are the pictures of diabetic uh, dermopathy that present on the shin bone, mainly with hyperpigmented patches, generally non-itchy and non-painful. These are the pictures of diabetes, necrobiosis lipoidica, lichen planus, diabetic bulle, diabetic rubeosis, acanthosis nigricans, and eruptive xanthomas. Among all other cutaneous complications in diabetics, and diabetic dermopathy is the most ignored complication and affects around 1/3 of the diabetic population. Diabetic dermopathy, shin spots, multiple round oval macules over the shins, thigh, forearms, hyperpigmented atrophy, twice common in older men, should have more than 4 lesions. This is a marker of microvascular disease and hence, as expected, has a high correlation with diabetic retinopathy. Diabetic dermopathy is a constellation of well-demarcated hyperpigmented atrophic depressions, macules or papules, located on the anterior surface of the lower legs that is usually found in patients with diabetes. It is the most common cutaneous marker of diabetes and it is found in approximately 1/3 of the patients and more commonly in the elderly. In a case series of 100 consecutive inpatients or outpatients with diabetes and skin lesions, diabetic dermopathy was found in almost 1/3. The incidence was much lower in a second case series of 500 patients. The authors concluded that because of the majority of the patients were well controlled, cutaneous lesions of chronic hyperglycemia was decreased. Sometimes seen in patients without diabetes, especially with circulatory compromise or peripheral arterial disease. Causes of diabetic dermopathy, the cause is mostly unknown and it may be related to post-trauma, mechanical or thermal, especially in patients with neuropathy. Lesions have been classified as vascular because histology demonstrates red blood cell extravasation and capillary basement membrane thickening. In one study, patients with type 1 diabetes and diabetic dermopathy had marked reduction in skin blood flow at normal appearing skin areas on the peritibial surface of the legs compared with type 1 control and non-diabetic control patients. Causes of diabetic dermopathy. There is a strong association between dermopathy and microvascular complications, that is retinopathy, nephropathy, and neuropathy. Women with diabetic dermopathy appear to have a more severe sensorial neuropathy, that is loss of DTRs, superficial sensory loss, and loss of vibration sense. A high prevalence of carpal tunnel syndrome was also associated with these patients. The appearance of diabetic dermopathy can vary from person to person. It is characterized by reddish brown, round or oval, scar-like patches that are usually 1 centimeter or less, typically asymptomatic, that is non-itchy, non-painful, non-inflammatory. Though lesions primarily form on the shins, they can also be found on the other body parts. However, they are less likely to develop on those areas. Other lesions that are found also include other sites, thigh, trunk, and arms. Although the lesions can be unpleasant to look at, the condition is harmless, does not usually cause symptoms like burning or stinging. patient can develop one lesion or cluster of lesions on the skin or other parts of the body. When spots develop on the body, they often form bilaterally, meaning they occur on both legs or both arms. Other than skin lesions, it doesn't have any other symptoms. These lesions or patches do not break open or release fluids. They are also non-contagious. Diagnosis: by doing a visual examination of skin and by evaluate the lesions to determine shape, color, size, and location. Treatment: tragedy is that till date we don't have anything that offers a helping hand. So we end up sending them to a dermatologist or advise few management tips like use of OTCs, moisturizer, or either emollients or oils. Majority of them believe that there is no specific treatment available and try to advise them either apply a makeup to cover the spots, or if dermopathy produces dry scaly patches, then use of moisturizers or oil containing aloe vera, glycerin, and liquid paraffin. Drawback: they work on loss or moisture or dry skin, but lacks in other properties like healing of skin spots, antimicrobial and antioxidant properties. Most of the moisturizer oils, they contain paraben, which means they are not suitable for every skin, has a high tendency to cause a high degree of skin irritation or inflammation. Diabetic patient's skin is already very thin or sensitive. So if a paraben containing topical item is applied, then chances of getting skin irritation or inflammation doubles. And we all know diabetes is an inflammatory condition. All the complications are inflammatory. If this is not a good option, what is the criteria? Use of topical agents that should hydrate skin and protect transepidermal water loss, reduce shin signs, inflammation, or fasten up reepithelialization process by increasing blood flow to the area and helping to create collagen fibers. If we get a benefit of antibacterial, antifungal, antiviral, anti-inflammatory activity and paraben-free, that is an ideal situation for our patient. So if we get all these properties together, hydrate skin, creates skin barrier, prevents itch intensity, prevents microbial infection, and facilitates healing, we will be able to manage diabetic dermopathy better. So anything that hydrates skin, creates skin barrier, prevents itch intensity, facilitates healing, and prevents microbial infection, we will be able to manage diabetic dermopathy better. So thank you all for your patient hearing, and we can take up the questions, if any.
Very well elaborated, sir. So I'll request the participants, if they're having any questions, they can put in the Q&A box. So your voice is not audible, sir.
We have one question in the chat box. how long it can be given. There is no limit as to how long it can be given. The patients have been taking for years and years, and no complications or risk factors. So it can be given for a longer period. And definitely the patient will lead for long periods, because the skin lesions or the inflammation is not going to reduce within few days or weeks.
There's another question for Dr. Aarti. Your voice is not audible.
Can it be used as a moisturizer? Definitely yes, but we don't prefer it to use only for dry skin or cracked skin. For moisturizers, we have other options, but definitely yes, it can be used as a moisturizer, but not solely as a moisturizer.
So I think so we can conclude the session.
Thank you.
So thank you, Dr. Jain, for joining with us today. It was really an insightful discussion for us as well as for our listeners. And I would also like to thank all the doctors for being with us and for your active participation during this. Thank you and have a great day. Thank you.
Thank you.